Dear ladies and gentlemen, my name is Helena Červinková. I'm from Czech Republic, from Palacký University Olomouc, and work as a speech and language therapist, and together with my co-investigator and tutor Červinková Vitásková, we would like to introduce the issue of the specifics of logopedic and special education intervention in children with psychiatric diagnosis. Stimulating and supporting family background is crucial for general development of child, especially for speech and language development. According to Damberga, children's adequate language skill is often an important prerequisite for the child to engage in successful social interaction, and one of the main distractors of successful development of speech and language is dysfunctional family. Children with specific language impairment have more often demonstrated, for example, aggressive behavior, destructive attention, heightened level of anxiety, somatic complaints, social withdrawal, and excessive shyness. According to Damberga, comparing with the children without language impairment, these behavior cause problems in the social area. Pokorná mentions types of reactions on failure of children with learning disabilities. The first types cover defensive and avoidant mechanism. Child refuses to cooperate, does not write homework, child is in opposition to school. The second types are compensatory mechanism. Child tries to push through, misbehaving. The third are aggression and hostility include weird relaxation by aggression, billing others. And the last one is anxiety. Children feel weak, they are closed, sensitive, restless, depressed. Psychosomatic symptoms occur with the last mechanism are vomiting, loss of appetite, sleep disturbances, decreased immunity. El-Sadi and his colleagues found out some reasons why the speech and language differ in children with ADHD in comparison with intact children. Because ADHD represents a group of disorders that affects processes essential in the development of language, attention, thinking, learning process, and social interaction of child. Because of lower working memory occurs in ADHD, it takes longer children with ADHD to process syntactically complex information, and children with ADHD have considerably lower accuracy in comprehension. Because of neurological origin, frontal lobe and basal ganglia involvement were claimed to affect both ADHD and language disorders. Communication disorders often appear in schizophrenia, mood disorders, other anxiety disorders, intellectual disabilities, pervasive developmental disorders, hyperkinetic disorders, conduct disorders. The goals of this survey are to analyze the environment, communication disorders in children, and psychiatric disorders in children, to analyze specifics of logopedic and special education intervention in children with psychiatric disorders, to verify the association communication disorders and psychiatric disorders, all in Children's Department in Psychiatric Hospital in Dobřany. Methodology. We worked with this research sample. All patients from Section B Here are younger school-age boys. And patients from Section A only who attend speech and language therapy. In the Section A are preschool children and school children. So, 21 children in total, 3 girls, 18 boys. Age varies between 3 to 17 years. This survey was done in children patients currently hospitalized in Children's Department. Now let me describe the Children's Department in Psychiatric Hospital in Dobřany, Czech Republic. The department was established in 1958. There are 3 sections. A. Preschoolers, girls, totally 17 beds. B. Boys in elementary school age, 18 beds. And C. Adolescents, boys, girls, 20 beds. Reasons for hospitalizations are behavior disorders, automutilation, adaptation disorders, affective disorders, anxiety disorders, eating disorders, incipient and developer psychosis. Hospitalization within diagnostic stay could be because of differential diagnostics of autism spectrum disorders and developmental diagnostic of children. We have an interdisciplinary team in the setting: medical doctors, senior consultant, medical doctors, psychiatrists, nurses, psychologists, speech-language therapists, occupational therapists, art therapists, and social worker. Here is a process from admission from dismissal. The admission is based on request of doctors, pediatrician, outpatient psychiatrist. When the child comes to hospital, he or she is assessed by all members of team after the medication is adjusting. We observe the child, provide therapy. We cooperate with family or children's home in leadership and education. When the health condition is stabilized, child could start to go to therapeutic leaves, home or children's home. After a dismissal come. In case of need, we monitor the health condition in outpatient psychiatrist, outpatient psychologist. During the week, the child obtained the care of medical doctor every day, senior consultant medical doctor once a week, nurses full day, teachers in the forenoon, educator to fulfill the assignment, in the afternoons with therapists, SLT, psychologist, occupational therapist, art therapist. In the late afternoon take place sport activities, hypotherapy. In the free time, children play games, have some competitions, trips or other group activities. The SLT care looks like this. The assessment in the cooperation with interdisciplinary team. The therapy is provided according to type and severity of communication disorder. Group and individual therapy with preschool children are in the forenoon. Individual therapy with the school children in severe cases are also in the forenoon. Individual therapy with school children is in the afternoon. There are some specifics in special education and SLT care. SLT has to cooperate with other members from the interdisciplinary team. The care results from a character of patients. Children come from dysfunctional families, children's house, and sometimes with syndrome CAN. The SLT need to know an anamnesis of children and work sensitively with children. Children should be tired and sleepy according to adjusting medication. The cooperation with the family is limited because of dysfunctional families. Often, diagnoses in children with psychiatric disorders are dyslexia, delayed language development, specific language disorder, specific learning disabilities, communication disorder in intellectual disability, stuttering, cluttering, communication disorder in autism spectrum disorder. Research analysis is mostly based on analysis of anamnestic data of children. Partial results of the investigation are related to the issue of specific learning disorders be related to the project IGA, Research on Selected Disorders and Differences of Communication Ability with focus on the specifics of speech and language therapy and special education for hearing impaired assessment and intervention, conducted at the Institute of Special Education Studies, Faculty of Education in Palacký University Olomouc, Czech Republic. This table displays the results of survey, the communication disorders and psychiatric disorders, and very brief family anamnesis. We can see that children come from dysfunctional families. Here are results for the section A for patients in special education and SLT care. We can see here the first part of results of communication disorder and psychiatric disorder with the brief family anamnesis for the section B, boys in younger school age. The second part of results. Here is a graph of participation psychiatric disorders in children with communication disorders in sections A and B. The most often diagnosis is significant impairment of behavior requiring attention or treatment in 37%. After is disturbance of activity and attention in 32% and hyperkinetic conduct disorder in 16%. Here is a participation of communication disorders in all patients hospitalized in section B. It's 87%. We can see here a participation of communication disorders in patients hospitalized in the section B. The most often is specific learning disorders and communication disorder in intellectual disability, both 25%. After is dyslexia in 20%. On the fourth place is with 10% specific language impairment and delayed language development. Only 10% patients in the section B have not a communication disorder. Here is total participation of communication disorders in both sections. The biggest participation has communication disorders in intellectual disability in 35%. After is specific learning disorder in 22%, dyslexia 17%, 13% obtain delayed language development, 9% gain specific language impairment, and the last one in communication disorder is autism spectrum disorder. The conclusions are: the professional background of psychiatric hospital in Dobřany is multidisciplinary. Children patients come from dysfunctional families. The association between communication disorders and psychiatric disorders is obvious. 87% of primary school children in the psychiatric hospital in Dobřany have communication disorder. The most frequent psychiatric diagnosis was F70.1, the need of significant impairment of behavior requiring attention or treatment. The most frequent communication disorder was communication disorders in intellectual disabilities with the syndrome ADHD. The presence of a speech and language therapist at workplace of child psychiatry is indispensable. Thank you for your attention. In case of questions, you can contact us on these email addresses. Here are references.